welcome back to the Digital Symposium 2018. My name is Paul Abrahams, and I'm here with a great panel of experts, Joseph Kunkela, Daniel Dunker, and the lovely Bertie Napier at the end. Welcome, guys. Pleased to see you. Have you enjoyed your time here at the Digital Symposium?
Absolutely. I'm first time here in the symposium. It's beautiful, organized well. Everything is great.
Good. Good. Bertie, you having a good
Yeah,
time?
it's been great actually.
Yeah.
Meeting people who are like-minded,
Yeah.
doing the same thing, catching up with people, getting tips. Really been good. Really enjoyed your talk this morning.
Oh, thank you.
Opens the mind a little bit. It does. Yeah.
And Daniel, Daniel's a technician, so from the technical side.
From technical side, it's been wonderful.
Yeah.
It's been wonderful. I've been just popped over to see the Henry Schein booth over there, and just playing around with all the equipment that obviously I've been using for a while now as well. But it's a really nice setup we have here. I really enjoyed the cruise last night. Wow. It was quite nice. It's actually my first time here in London in my adult life, so.
Fantastic.
And you was blessed with proper London weather as well.
Absolutely.
Yes, it rained the whole time.
I suppose from the perspective of it's great having Joseph and Daniel here, because I think a lot of what we've seen today and through the weekend is about the dentist-technician collaboration and how important that is. I think particularly with a lot of us in digital dentistry, we get obsessed with single-visit dentistry, but there's so much more. Today, particularly, we had a lecture on biocopy. And in terms of that collaboration, explain a little bit more about biocopy and where we can go.
And first about this collaboration, I think to all CEREC users, the beginning start to work with the CEREC alone because they give us the freedom, because we can do everything when we want and how we want. But if I compare the timing, that's mean how much time I invest to each procedure, now we see that I'm totally inefficient if I'm working like a dental technician. And I'm happy that I found to Daniel, because he is super addicted to digital dentistry, and we cooperated really like a team, like a partner, and I'm more than 30% efficient because I concentrate for my job. That's mean the preparation, the scanning, the bonding, and also to improve my part, to dentist part. And Daniel decided to be like a team in office. We are not like in a separate room. We have the open space. We are working together with a patient. During all procedure, many times happened that Daniel start with the scanning before.
So is Daniel actually doing the scanning in office?
Absolutely.
Yeah. That's interesting.
Well, I mean, you pretty much what's actually one of the most important things in dentistry is you guys as dentists, your time is way more valuable than any of your staff. And if you have a capable person that's on your staff that can scan for you, he's saving you a lot of money by saving you some time. And so because I'm working with CAD-CAM, I'm working with NLab, I'm working with OmniCam and everything like that, I know how to scan. Sure. And I know how to scan very efficiently. And so if I can prepare that case for the doctor so he can just come in and then afterwards prep and just cut out the little area where he prepped and then just rescan that within just like a blip situation, it's much more efficient for him than if he has to do the whole upper and lower and do your buccal bite and everything like that, put in your obtugate and kind of mess around the whole time. So
see, that's interesting, isn't it, Percy? Because that's like a different mindset, I think, for all of us guys. That's hearing
it is, and I think especially for older dentists, the grey hair, it's shifting away from that thing that you are the king of this castle and you have to do everything. And what I've found is every time I have asked my team to do something a little bit more, they love it. I've got a trainee who sets up the computer, the CEREC, puts the details on, sets up what material we're going to use, what procedure we're doing, and she loves it. And it's the one thing that she's so good at. So next stage is now, let's teach her how to scan.
Sure.
Because I reckon she will just take to it and just go with it.
And next step to place the rubber dam.
there you go.
I mean, it's actually a great way of engaging our team. That's the thing. That's the other thing about digital dentistry. It's something new to everyone in the practice, and I think it shouldn't be something new, but we can involve so many more of our team members and make it so much more of an interesting experience. And I think our patients see that as well. That everyone's so much more engaged by this process going forward.
I think, Paul, as well, is your whole team looking at the type of practice that you're presenting to the outside world and to your patients. When we've gone digital, they love it because they are so proud of, look at us, we do things differently. Patients can come in, it's comfortable, you don't have to have impressions anymore. There's a completely different way of doing things.
So on a more, Joseph, on a more technical level, explain a little bit more about biocopy.
Yeah, sure. Everything started with the initial scanning I mentioned before, because we delegate, we have delegation in our team to prepare the initial scan from dental technician part or from assistant to save initial data, because this initial data give us the opportunity to repair the patient's smile with the same condition. It's a real biocopy, and this opportunity give us to repair all the damages, to give them back to initial situation. If the patient, of course, if the patient has the beautiful initial situation. If not, we can use these initial scans from, for example, another patient, like a donor, for a patient need to improve the smile.
Because that's an interesting area, isn't it? The ability, I think, scanning anyone and everyone that comes into the practice. If a patient wants to look like Cristiano Ronaldo, if you've got him, you can scan him, and you can use that data and impose that on anyone.
Unfortunately, we can copy it only the teeth, because we are dentists.
That's perhaps
can
the
be
way one,
interested to also to looks like Ronaldo. And
different thing. And in terms of, obviously a lot of us again are working with software within our current Omnicam or CEREC in surgery, and again this collaboration, the in-lab software is obviously very important in this. I think particularly in these bigger cases, these big cosmetic cases, it's very difficult to do these cases without that collaboration in the lab. So again, can you explain a little bit about how that in-lab software, what you can do more, am I right?
Well, the in-lab software is pretty much an expansion of the CEREC software. The basic way it works and everything, the whole setup in there is pretty much the same. Except you have a little bit of a different interface, and but you have more options. You have more indications. You have more of an integration of many more elements that you can incorporate in there. And the nice thing about that is that what Dr. Kunkela was saying is that when you take and you copy someone else's teeth, someone else's design, or someone else's natural smile or whatever, you can superimpose that and literally merge those two catalogs together and do your design with that other person's teeth and just match it into your margins. It's great. So it's just it gives you the freedom of just doing pretty much whatever you want. You're just and the thing about that is a lot of people say, okay, I have a CAD/CAM system, and so the CAD/CAM system is going to do everything for me. No, it's not. You're the one that's going to be telling the CAD/CAM system to do it for you, because it's not. It's just a tool. It's just like a dental technician. He has a model, he has a wax knife, he has a scalpel, he has whatever other tool that he's using, and it's up to him to how he uses it. And it's the same thing with CAD/CAM. That
was a very important thing that actually came out in the lecture. I think Dan appreciated. People get obsessed with how accurate is this machine. Yes. No one ever asked the question. That's really an important point that you made. How accurate is your impression? How good is that material? How well poured was that model?
Well, how accurate was your preparation?
Correct. So the bottom line is there's still a human behind the machine. It is a tool. I think, from my perspective, I know when I started scanning, it improved my dentistry, because when you've got your prep on a screen in front of you blown up 6 times the size, and you're only ever seeing it, maybe if you're lucky, through your microscope, and those guys, let's face it, aren't doing that, then it can only improve what you do. And that's an aspect that gets missed.
It takes your dentistry to another level. Takes it to another level. When I was listening to you, Joseph, with the biocopy, where you're almost creating a catalogue for a patient of, I see you for the first time, You're 16 years old. You have
Yeah.
beautiful teeth.
Absolutely.
Let's get this in 3D.
Yeah, yeah.
Put it away for
Yeah.
a day. We hope we'll never need it, but for a day we might need it. I have had a patient recently who had, she thinks her teeth were fairly beautiful, but she decided to have no prep veneers. Had them and absolutely hated them because it changed the shape completely.
Yes.
Now, unfortunately, in this case, there's no preoperative photographs, there's nothing. So the photograph the patient brings in, you can just about see
Yeah.
the smile, but there's no detail. Something like that, before we start, which is one of the great things when you talk biocopy, is you've got to scan before you start, before you touch anything. And I think what you've just said with let's get a scan of the original situation and always have it.
Should be routine.
Absolutely, yeah.
We should be
Yeah.
scanning every single patient
That's
that walks
it.
through the door, and that
Yeah.
should be put to one side
That's
and
it.
stored, because when they collect a golf ball
Yeah.
on a golf course and fracture
Yes.
2 or 3
Yes.
or one front tooth,
Yeah.
you've got them, as you said, in 3D.
It's the
so-
same routine like the X-ray taking.
Yeah.
Usually we delegate this process to receptionist
Yes.
or the assistant. They are doing.
They'd love it.
Yeah.
They would love it.
Just why not delegate to do the scan,
Yeah.
intraoral scan?
Yeah.
Yeah.
Another important question, I think, in technique, again, coming down to as opposed to the broad digital issue, I think important thing that you covered in the lecture is immediate denting sealing. I think that's something that gets discussed a lot, but I think having been on your course, I think that's something now
Yeah.
I've adopted. Could you explain that to a little bit in your philosophy behind that?
Immediate dental sealing is not my idea because it's
Yeah.
more than I think 15 years old
Sure.
technique. What I know that's Pascal Mine is like he's developer of this technique. It's very easy because many times happen also during my practice that's happened that things like post-operative sensitivity sometimes, especially in a deep the reconstruction, like a deep restorations after removing old amalgam fillings. The dent in this area is very sensitive, and also the dry and checking the restoration is also another process when anesthesia is completely out, and it's a question about to start another shot
Yeah.
to remove the sensitivity or to explain the patient, yeah, it hurts, but please wait.
Yeah.
It's
We're all,
it's
we've all
other
been
things
there.
like that. It's once you will seal immediately to dentin, you have a lot of advantages. It's like reduce the sensitivity, also better bonding strength,
Yeah.
and also some imperfections on the preparation.
Yes.
You can cover it to very smooth, beautiful surface. It's amazing.
I mean, I think actually that it's a very important point in our everyday CEREC use,
Yeah.
in office use, because most of us have that procedure where we do a single crown on a vital tooth, and you're feeling like you need to top up the local, which is a shame. So I think it's something that I think most of us could adopt and
Yeah.
realise it's going to improve the experience of the patient as well. for sure.
Constantly giving them a warning it's going to be sensitive afterwards.
Yeah.
When
Yeah.
you've
Yeah.
sealed it beforehand, the likelihood of that is much reduced.
What do you think, Daniel, about dental sealing?
Well, if you're a patient-
This is actually kind of your field, but what do I think about it? Of course, I mean it makes sense.
yeah.
Daniel is responsible also for dry checking. He has
Yeah.
own chair
Yeah.
like a dentist. He's doing also the dry and
Yeah.
restoration. He knows that also. That's why this question
Yeah,
is not
no,
about.
no.
Yes,
Well, I suppose so. The other question, Daniel, is in terms of for both of you really, in terms of materials, what's your preferred? I mean, obviously, a lot of us are using Emacs. Do you have a preference for materials for your? I know you do, but I'm going to ask you the question anyway.
Yeah, but usually, it doesn't exist the material like the magic wand for everything.
Sure.
Usually we choosing the material according to condition. It's a non-prep restoration, or it's the prep case. It's an inlay only where it's the most complicated surface. It's chipping or the fractures, the margin fracture, easier than a crown
Yeah.
preparation. By the way, we have also patients with strong bite, bruxists.
Yeah.
As another case, also you have to prepare the different material for this situation, and also anteriors. We prefer for anteriors like multi-layered
Yeah.
materials.
So that's like the Empress and
For example, Empress or Katana multi-layered.
Yeah.
Different kind of the multi-layered materials to improve aesthetic view than single monocolor
yeah.
block.
And Daniel, in terms of finishing these things, I mean, it's
In terms of finishing, every one of the materials is different. I
Yeah.
mean, you have your composites that you mostly just polish. I mean, there's glazes, there's light curing glazes as well, stains. Also, but when you're talking about finishing, you're also talking about the coloration of the restoration that you're trying to give it, and this is kind of one of the main points that Dr. Kunkela has been trying to get through my thick skull. To be honest with you, this is one of the things that we've been struggling with from the very beginning, and we're finally getting to the point where we've agreed on the fact that too much stain, too much shading, too many effects, too much fake pigmentation, crack lines, and all of that stuff is quite unnecessary for one.
Drowns
But the
everything else.
most important is unwanted.
Yeah.
The patient doesn't want it.
Yeah.
They come into the dental office and they're like, okay, I want to have a new tooth. I don't want an old tooth. And what you do as a dental technician, and dentists have the same tendency or whatever, like, oh, I'm going to make this a work of art. You know, I'm Michelangelo. I'm just like, yeah.
I'm gonna
That's
make
what,
it.
And-
Daniel has now this experience because he's in a real touch with the patient
Yeah.
daily.
Yeah.
If he's sitting somewhere in a room behind a table like a dental technician with a plaster or 3D printed model, he has never this experience. What
So
this
he hasn't seen the
patient
dentist polishing out
interaction.
that nice
Absolutely.
little brown
Well-
stain that you've put into the top of the mouth. for instance. Now you've seen that happen. So yeah.
Yeah.
Well, use this old
I put
plastic
it there
coins.
and it just
Or-
goes
or
gone
the message-
anyways. Yeah.
The message you send back after you sort of fit this beautiful smile makeover, where a patient comes back a week later to take the photographs, and you think, what's that brown mark on the edge?
Yeah.
So our
It's
technician,
so polite.
can
Brown.
is that surface stain that you've put on, can I polish it away, or is it something deeper?
Yeah.
No reply.
Yeah.
So you can't get rid of it.
They always I receive this the answer that I can do my own pigmentation alone. I don't need your brown spots in a fissure. But it's true. But you know, it's about our dentist view. We are super like the natural addicted.
But that's what we
to
do.
surface,
Yeah. I think again, coming back to even yesterday, the lecture, the sort of talk in the morning, and then yourself as well. And again now with the guy who's doing the lecture, the orthodontist, saying the same thing, that it starts. The patient has got to be the center of all of this. It's what the patient wants.
Yes.
The technology is brilliant,
Yeah.
but it's all back down to what the patient wants.
Sure.
Well, on that, actually, what's interesting again in your presentation was again utilising things like facial scanning software.
That's
And I
amazing.
know, again, having been on your course, which we're privileged to do, just actually so much of that software is free to use as well.
Absolutely.
But do you see that being
Easy to
integrated
achieve,
more and more actually within the CEREC? Do
Yeah.
you see that coming?
Yeah. It will be integrated like a real condition, real 3D face with our intraoral 3D scan and without distortions, with the old beauty, old like symmetricity, golden proportions which we can achieve from the face
Yeah.
scan.
And it only helps the patient.
Yeah.
Okay, gentlemen, thank you very much. It's been great
My
having you here
pleasure.
today.
Thank you.
And we look forward to more in the future. Thank you.
Great.
Thank you.
Thank you.
Thank you.
Thank you, guys.
Thank you.